Chapter 27, we are going to talk about value-based healthcare and its financial and digital outcomes. So value-based concept is something that's trending. Value-based has come to mean a combination of both quality and cost. So essentially, the better quality care you provide, the more money you would be reimbursed. There are some side effects of this that I'll try to remember to mention. But on page 333, bottom of the page, it says, this chapter therefore addresses different facets. Welcomed. Let me start that over. The chapter therefore addresses different facets of the value-based concept in healthcare finance and related financial management. This chapter is divided into several parts. And I'm not going to, well, I don't ever read because you guys are adults and can definitely read. But some of this I'm going to skip over and just tell you to read on your own. Okay, so let me flip the page. 334. The remainder of the chapter will discuss progress in the private and public sector, education efforts, legislative reform, quality measurement, public reporting, financial and digital outcomes, strategic planning approaches. More value equals more money, basically. So value-based progress in the private sector, there are examples given there. Value-based collaboration and affiliation, there's more examples. Value-based progress in the public sector. So Exhibit 27.1 does an excellent job at listing out the 7 federal value-based programs. So the hospital value-based purchasing, hospital readmission reduction. So if you have less readmits, you get paid more money. Hospital-acquired conditions. So a nosocomial infection is an infection that is acquired within the hospital. In other words, the patient didn't arrive at the hospital or the doctor's office with that infection, but they left with it, or it happened while they were admitted or visiting or whatever. So as long as you don't have that, you get paid more money. Skilled nursing facilities have their own value-based program. Home health, end-stage renal disease. Renal disease patients have a whole different coding, billing, etc. Federal funds, that's just a whole different sector. Okay, so value-based progress in the public sector, page 335, flipping over to 336, talks about 3 hospital-based value programs, 4 other. I'll let you guys read that. That's physicians, skilled nursing, home health, end-stage renal disease. Value-based payments, the traditional method to pay for services delivery was by volume. CMS, the Centers for Medicare, are now beginning to pay for value. We've talked about that. 337, value-based educational efforts. Well, we have to teach people how to use the new electronic health records and coding systems, etc. And so that's the digital impact. Because every one of these certificates or this education that's listed, they're all online. So page 337, 338 talks about the education part. Value-based legislative reform, the middle of 338. These are all initiatives from our governing bodies. I'll let you read that. Important to know here, value-based legislative reform on page 339. The MACRA, I want to say MACRA, but I've heard it called MACRA. You can call it say it however you want, but for me it's MACRA because there's 2 vowels. So that's the Medicare Access. I'm going to get it wrong. No, that's right. Medicare Access and CHIP Reauthorization Act 2015. So this was in 2015. We're already in 2022. Things have changed. Things will continue to change. This is ever evolving. More value-based legislation, the impact, improving Medicare post-acute transformation, acute care transformation. Quick facts about physicians and the MACRA, the MIPS and the APMs. MACRA reform Medicare payments to physicians and certain clinicians via the following. They repealed the SGR, SGR. That was a prior method of paying for physicians, nurse practitioners, etc. for their, it was volume-based. So moving forward, where they've gone on with the value-based. MACRA reforms help CMS to move towards the value-based goal, paying both value and for better care. Physicians and other eligible professionals, such as PAs, nurse practitioners, they can choose one of the programs. How they can actually choose themselves. They have the freedom to choose which reimbursement program will suit them better, which one's going to get them more money. What is MIPS? There, that goes over that again. I'm not going to read it to you. New value-based program. Page 340. What are APMs? So although I'm not going to read it, I want you guys to know the difference between the MACRA, the MIPS, and the APMs. Meaningful use is mentioned on page 340. It's something that was very challenging when it first came out. It was they measured and they reimbursed off of meaningful use, but the government agencies didn't provide a definition for it, so a lot of healthcare folks struggled with exactly what does it mean. So it's still around, but it's ever evolving. The meaning of meaningful use, how you use it as a measure, is ever evolving. Quick facts, data interoperability, transparency. Transparency and public reporting on page 341. You can actually, there was a news story recently on the cost of MRIs in this area, but you can Google or call each healthcare institution for the different costs and take it a step further and ask them what it would cost if you used insurance versus what if you were a cash patient. Maybe you'll be surprised, maybe you wouldn't be surprised at all, but there are different pricings for insured people versus cash paying people. That's just part of how the system is. Quality measurement, the concept of it. Quality measures in the private sector are discussed on 341. Quality measures in the public sector are discussed on 342. Challenges for managers on page 343. This is real. Hardware issues, software training, staff stability. This is not just in hospitals. This is medical offices, outpatient surgery centers, skilled nursing facilities, hospitals. Yes, challenges for managers are everywhere. So continuing on 343, value-based public reporting in the private sector. Value-based public reporting in the public sector is on the next page, 344. Keep reading through those pages. Page 346 on financial outcomes. This section discusses several types of value-based financial outcome. There's an example, model. Duke University and Kaiser both are mentioned in this book, or these chapters, quite a bit, because they're huge entities to compare. Digital outcomes, how digital outcomes benefit a physician practice. Another example on page 348, what are value-based digital outcome examples in the healthcare systems? So they use Duke University and Kaiser again. Another outcome on page 349, electronic transmission standards must be updated and maintained. Then we have value-based strategic planning for the private sector. Flip the page, you have it for the public sector on page 350. Page 351, Exhibit 27.2. These are the 9 layers that can be activated for strategic alignment. This is a decent-sized chapter, you guys. 27.1 is the, excuse me, it's the table that explains the lever and how it should work, coming from the 9 levers on Exhibit 27.2. More tables. Conclusion to the future, changes still to come. Leadership is the essential ingredient. This is such a valid point. One thing is clear, an organization is to meet their value-based goals, whether their organization is small or large. Leadership support and encouragement is essential. This quote sums it up. The investment required is as much in leadership as in dollars. Who said that? Let's see. Because that's actually a good quote. Side note. Oh, it's from a book, I believe, Kaiser and Lee. Anyway, okay. So please ask me any questions about this chapter. I think it's straightforward, but it may not be. Value modifiers, if any of that, shows as a challenge, just let me know and we'll work through it. Thanks so much.